shadowing, I know many of you are pre-med. You certainly, I'll give, sorry.
Ajay.
My email address. You guys can certainly come over to the hospital, shadow us. Also, I'm looking for people to help me out this summer on research projects. So if any of you are looking for a summer, potentially summer job, I may have some funding. So give me an email. My disclosures are, I don't have any conflicts of interest, no drug company affiliation. I'm an Oakland A's fan. Who likes baseball. So I want to take you back to like the early 20th century, sort of the dawn of somewhat evidence-based medicine. Basically, at that time, still being a physician was somewhat of a cottage industry, and you know, formalized training had just started, but mostly it was the doctor and the patient. There weren't a lot of other healthcare providers, and there wasn't a lot a doctor could do. So, for example, for congestive heart failure, which is a very common ailment in adults, elderly adults, you could give digoxin, a leaf preparation of digoxin. Basically, they ground up some leaves and gave that to patients. They could give an aspirin. They could bleed the patient if they came in. The problem with congestive heart failure is often they have a lot of fluid on board, and you have to get the fluid off. Well, bleeding was a primitive way to do that. And even in the 1930s, that's what we were doing. For pneumonia, it's known as the captain of the men of death. William Monson was one of the founders of evidence-based medicine. It had a 30 to 40% mortality rate, so if you got it, 3 out of 10 of you would be dead. They used arsenic, serum therapy, I don't even know what that is. And actually one of the recommendations was to move to a warmer climate. There's a famous architect who got a bad case of pneumonia and ended up moving to Arizona for that reason. Does anybody know? All right, I'll always think about that. So this is I grabbed this from Google. This is sort of supposed to represent the number, sort of the increasing complexity of medicine. So in the 1940s, 30s, there were very few things we could do for patients. Then the number of drugs that came out went up exponentially. Antibiotics came in the 1930s, 1940s. The number of treatable diseases also went up. This is not actually to scale or accurate, it's just more of a visual representation. So there are 6,000 known diagnoses now, there are over 4,000 medications. The average number of diagnoses per patient on my service is about 5 to 7. The average number of problems addressed during a physician visit is 6, and yet the time for physician visits has been shrinking. And some of you may have experienced that in primary care visits or subspecialty visits. The average number of prescriptions filled per year for a Medicare beneficiary is 24. So that's 24 prescriptions, potentially 24 drugs, usually less than that. But I think the average number of medications that I discharge my patients on is probably anywhere between 10 to 12, 10 to 15 sometimes. And then, so in a hospital in the 1930s, it would be the physician, the nurse, and the patient. Now it's up to 15 different allied providers. We have physical therapists, occupational therapists, nutritionists. We have the nurses. We have case managers, social workers. We have a bunch of subspecialists, and our really complex patients, like our CF patients, will have a lot of different folks seeing them. So if you can imagine trying to coordinate all that care is incredibly difficult. Just an example of how far we've come with congestive heart failure. This is Dick Cheney. He actually recently got a heart transplant. Before he had what's known as an LVAD, which is an external heart pump that basically replaces your heart. And this is the congestive heart failure guidelines for 2009. I don't want you to read this, but this is how complex it is. There's all these different steps, and yet we're still training physicians to be sort of like this guy, the cowboy at the beginning. Okay, the country doctor who is supposed to be able to know all this information, assimilate it all, despite the increasing complexity, the increasing number of drugs, procedures, things, and we expect them to know it all, the primary care physician to know it all, and to do it. And unfortunately, we're failing, and I'll go over that a little bit. So here they looked at preventative care, how primary care physicians were doing preventative care in a study, and there were 19 guideline recommended preventative strategies. Colon cancer screening we're doing pretty well. Breast cancer screening we're doing pretty well. Do you guys know why we're doing pretty well? Anybody know?
Strong outreach programs?
Very strong outreach programs. You know, like the Komen breast cancer group and others. Katie Couric going on television getting colonoscopy. But actually, honestly, the more cynical view is that these things have really high reimbursement rates, and there's a lot of pushing from subspecialists, really radiologists, GI docs to actually do these screening tests. And so, and I'm not saying we shouldn't be doing it. I'm just saying that's why we do so well in those. Aspirin use, which costs a couple cents per pill, is 18%. And influenza vaccine was 20%, very cheap therapies. So as you can see, there's a huge sort of gap in evidence-based preventative care. So the overall rate of guideline, preventative care guideline adherence was 54%, so we are definitely failing. I want to go over remember a case, this is at one of the hospitals I used to work with. There was a patient who comes in, she had a history of a renal transplant, a kidney transplant, and when you get a kidney transplant, you need medications to help prevent rejection. And the intern filled out all the paperwork for discharge, which was basically, it's still a paper-based discharge system. So if you can imagine, with 4,000 different drugs, and my patients, particularly this patient, on multiple different medications with multiple interactions, we're still sending patients home with paperwork that then gets faxed to the primary care physician. And this is the medications, I'm not going to bore you with it. Basically, one of the crucial medications was just simply left off. One of the anti-rejection medications left off. As a result, the patient went into renal failure and lost her kidney. So this just happens all the time. There are up to 100,000 deaths from medical errors, and up to 25% of hospitalizations are associated with a medical error. So this is a big one, obviously, but this is an example of why information technology is going to be so important in sort of putting all this complexity together and making it more seamless as far as the transition. Here's discharge paperwork at Georgetown from 2003, and here it is in 2012. Same thing. Despite the fact that we know that this kind of mistake that could happen anywhere has happened at Georgetown, has happened at Fairfax, has happened at all the hospitals around here, and yet all of them, and not all of them, but many of them are still using triplicate-based discharge paperwork, which I can pass around if you want to take a look at it. So, and so we discharge these patients, and again, we're acting like cowboys. We're not communicating with the primary care physician. So I don't see patients in the hospital. When I discharge them, I send them out to, where's Rachel? I send them out to Rachel. And so, as she'll tell you, we suck at communicating with them. 12% of my discharge summaries make it to the PCP, although I do much better than that, I think. Only 17 to 20% of primary care physicians report being consistently notified at the time of discharge. Outpatient clinicians say their follow-up management was adversely affected. A quarter of the time, it's probably higher than that. There's a lot of primary care dissatisfaction with this process. And then here's a discharge transitions in the literature slide. So basically, all it's telling us is that there are labs ordered that they're not followed up on, mostly because the primary care physician is not really told about the lab, and sometimes bad things happen. And so this is, I'm going to skip because I'm almost out of my set. I'm probably 7 minutes into this, but this is just another example of a case that could be prevented. So my point is really, should you consider yourself a high-quality physician if you work in an organization that is not systematically trying to improve itself? But actually, should you guys consider, it's really about our country's priorities. So we have the Hitech Act, which is in 2009, which basically mandated the adoption of EMRs going forward, but they did it over like I think a 6 or 7 year period, and they're phasing in different parts of the expansion. So the first phase is set to start, I believe, in 2014, but what it's requiring is that we have electronic healthcare systems. So it may not come through in this talk, but that is really one of the major solutions to this problem, is having a universal electronic healthcare record, like the system like Kaiser has. If you've ever been in a Kaiser system, they have an EMR. If I discharge a patient from the hospital, I email the patient's primary care physician. They have access to the same information I do. We don't have that. So it's really been a lack of prioritization in our country. We've had the technology to do this since the 1980s probably, and yet we have chosen not to, despite lots of data to suggest that it does better. A lot of European countries don't have these kind of medical errors because they have a better system. So I guess to sum up, what I'm trying to say here is that medical care is much more complex. We really need to push our government to have EMR. The solution that we have is actually not perfect, by the way, if you study it. We can talk more about that, because really they aren't really necessarily requiring that all the systems talk to each other, which is one of the biggest downfalls of it. There's things called health information exchanges, which are going to be local networks of EMRs, but I can't see that there's really a good national plan to try to integrate them all. So the point is that we really need to push our representatives, write your congressman, tell them that this is really important. We need to have EMRs so that we can stop preventing errors like this. It was a little bit disconjointed talk, but that's all I want to say.